research to look at and figure out what we talk about the peri-operative complications, there are two things that were very important. One is that there was a real paucity of articles on I consider my alma maters, MBBS, and this is Jefferson Medical College, the oldest medical school in the United States, where I did my postgraduate training in medicine and gastroenterology. So I think, I don't never try to put that. I could make it, if you just excuse me, audience, I have my travel drive. So, I'll get started. We talked, so as I told you, just to refresh everybody's memory, if you forgot. When I tried to do a literature search, there's a real paucity of articles on this subject, but the articles that are there were dealt with really large patients. I always like to start with a little history. The first surgery of the heart was performed by a Norwegian surgeon, by Alex Cappelen. It was really a long time ago, 1895, at a place which is now called Oslo, at that time called Christiania. What he did was he ligated a bleeding coronary artery in a 24-year-old man who had stabbed in the axilla. And the procedure was done through a thoracotomy. The patient awoke, did fine for 24 hours or so it seemed, soon became ill with fever and died on the third post-operative day. Story goes that post-mortem showed mediastinitis. Obviously, we've come very far from that. There have been constant advances in operative techniques, in the post-operative management, but the problem with that has been there has been extension in the selection criteria of our patients. We are now accepting sicker and sicker patients, old patients for all kinds of surgeries, including cardiac surgery. Therefore, the overall morbidity in some ways has increased. Patients not only have cardiac complications, but we also see an increase in post-operative incidence of extra cardiac complications. Luckily, the GI complications are not that common after cardiac surgery, with most data showing that the range is about 1 to 2%. Something's not very far. This is a farmer's market even today at Jefferson. It's held about once a month for patients, families, and physicians, and all kinds. And you can get all kinds of cheese, fruits. Some are good that they have not changed. And you'll see farmers market periodically in different parts of Philadelphia and the whole United States. Why is this topic important for us? Because even GI complication is not common. It's pretty dreaded because you use a lot of hospital resources. There is high morbidity and mortality, and depending upon what study you look at, the mortality and morbidity could be as high as 11 to 63%, although most studies quote about 22%. The other problem is delayed diagnosis is a big problem. Why? Because these patients are on different kinds of analgesics, and therefore the symptoms can be masked. Those that are intubated or sedated, they don't tell you about the symptoms, and the symptoms themselves can be very non-specific, except for GI bleed, which I talked about yesterday, which is obviously obvious when the patient is vomiting blood. The other symptoms could be nausea, loss of appetite, plus they do not occur immediately. They can occur anywhere 5 to 10 days after surgery, and that is a problem. Prior GI history has no role in predicting which patients of yours are going to get a GI complication and which are not. So my objectives today are going to be just to talk about some existing data that we have, look and see if we can figure out some kind of risk stratification and come up with a score for these patients so that we can predict who can develop post-operative extra cardiac complications and come up with some recommendations. In 1957, Dr. Berkowitz was the first to report life-threatening complications after cardiac surgery. He noted 7 patients that had GI bleed. 4 out of the 7 patients died, not surprising. Even today, we do know that the most common GI complications after cardiac surgery are GI bleed, paralytic ileus, cholecystitis, mesenteric ischemia, pancreatitis, hepatic injury, which I did not mention. What is some of the existing data? Let's start with a study in 1994, which was published in the Journal of Thoracic and Cardiovascular Surgery. It was a Swiss study. There were about 3,000 patients that had undergone CABG. And what the authors did is they looked and identified patients that were at high risk for GI complications, and they looked and saw and wrote for us what the risk factors were. So let's have a look. Out of 3,129 patients, 73 had GI complications, which came up to about 2.3%. The mortality was much higher, 16.4, compared to the overall mortality of the patients who had undergone CABG but did not have GI complications. They had a mortality of 3.4%. The most common GI complications in this study were intestinal ischemia and cholecystitis. And what were the risk factors? Not surprising, pre-operative hypertension, left ventricular ejection fraction less than 40, age greater than 70 years, reoperation, urgent operation, NYHA, heart failure class 3 and 4, peri-operative MI, so on and so forth, plus placement of intra-aortic balloon pump. They also, when they looked at the independent risk factors, the authors noted that post-operative low cardiac output and splanchnic hypoperfusion were the two most important independent risk factors. Let's look at another study. This was a Turkish study published in 2000. It was retrospective, just like most of them. 4,000 patients over 3-year period. 24 of the 4,000, so not a big number at all, developed serious GI complications. And what were them? Again, GI bleed, enteric ischemia, pancreatitis, hepatic dysfunction, and cholecystitis were the common GI complications. Mortality, if you see, once again was pretty high, 41.7%, compared to patients that did not have GI complications who had a low mortality of 1.89%. If you read this study, I have the reference here, it was pretty well done. The criteria was very well defined, and their risk factors were similar to the prior study from 1994. I did something on this slide I usually don't do in talks, but what I did is I combined two studies, so they used up time. One is the University of Cologne study that was published in 2006, and other is the large Cleveland Clinic data that was published in 2010. If you look at the titles, both were kind of looking for the post-operative GI complications. Now, they were both single-center studies, very large. The Cologne has about 9,000 patients, and the Cleveland about 16,000, so huge studies. The conclusions of both these are very similar. GI complications are uncommon, right? We know that, but associated with high hospital cost and mortality. Type of complications were similar in both. The risk factors for development of GI complications were slightly different. Let's spend a few seconds talking about that. In the Cologne study, which I have put in orange, surgery of the thoracic aorta, prolonged cardiopulmonary bypass time, and rethoracotomy were the most important risk factors. In the Cleveland Clinic data, use of fresh frozen plasma and placement of intra-aortic balloon pump were the two most important risk factors. And very interesting because both our speaker from Australia, the physician who left, and Dr. Puri said how fresh plasma administration could be detrimental to our patients, and this is exactly what this study brings up. The Cleveland Clinic study saw that the use of FFP increased the risk of having GI complications about 4 times. And why was that? Well, one could argue that these patients were sick to begin with. Well, that's possible. But the other cause could be that FFP administration has its own problem. Allergic reactions, transfusion-related lung injury, pulmonary edema, all this leads to severe inflammatory response, hypotension, splanchnic hypoperfusion, acidosis, and ischemic injury. That could be one reason. The other, we do know from other studies that there is a well-defined association between fresh frozen plasma transfusion and infectious complications and hospital mortality. Yes, there is no doubt we need more evidence, but this once again tells us that sometimes, and we as gastroenterologists are culprits as well. Every time we want to endoscope a patient, we perfect INR. But this just tells us that FFP administration is not without its risks. If you look at the pre-operative intra-aortic balloon pump insertion, because that was the other factor in Cleveland Clinic study, again you can argue that these are dynamically unstable patients, they have a low cardiac output to begin with, and that is true. But in addition, IV insertion by itself, as you know, can cause thrombus formation, embolization, platelet consumption, and thrombus formation embolization will predispose or could predispose some mesenteric ischemia and ischemic colitis. Platelet consumption could predispose or worsen your already existing GI bleed. In addition, as you know, intra-aortic balloon pump insertion can be followed by anticoagulation, and then that itself poses a problem. So what are the conclusions from the Cologne and Cleveland studies? And what were the drawbacks? The drawback was, of course, they are both retrospective. That's always a drawback. And when it's a retrospective study, certain data are missing. And in this case, we didn't have very clear information. We just have to be able to comment on that. But intra-aortic balloon pump insertion was associated with increased risk of GI bleed. But the most important conclusion, once again, was to be very prudent in administering blood products, including fresh frozen plasma in this case. The Cologne study showed association of the GI complication with prolonged cardiopulmonary bypass time, and I know all our 3 chairpersons and anesthesiologists, but this to date remains controversial, has not been reproduced in every single study. This is just downtown Philadelphia. The reason we have the letter love is Philadelphia is called the city of brotherly love. This was a name given to Philadelphia by William Penn, founder of Pennsylvania, years and years ago. I think the city has lived up to its reputation. It's really a small, very nice town, and if you guys will ever visit, it will be just wonderful. Now, let's switch gears and talk, what if we had a scoring system? What if we knew which of our patients are going to develop complications? Maybe we can be extra careful with them. So a group from Sweden looked to see a risk model could be developed to assess or predict GI complications after cardiac surgery. And this was published last year in Interactive, Cardiovascular and Thoracic Surgery. Their aim was to develop, evaluate, and validate a new risk model. And what they did is they called this new risk model Gastrointestinal Complication Score, or GICS, and they used it developing a lot of data, about 6,000 data prospectively collected about 6,000 patients who had undergone an equal number of cardiac surgical procedures between 1996 and 2001. And what were the things they saw? Let's focus on the first column and the last column rather. So these were the variables. If the patient is greater than 80 years, they got a score of 2.5. If they were an active smoker, 2.5. If they had positive ionotropic support pre-operatively, 4. And you can go, I'm not going to read every. If they had post-operative vascular complication, a score was of 9.5. And what they did is they calculated each patient's score based on all these variables: age, smoking, ionotropic support, the CHF classification, New York Heart Association, cardiopulmonary bypass time greater than 150 minutes, post-operative AFib, CHF, and reoperation. Oh boy. So this model was then validated on about 1,000 cardiac surgery patients. The authors concluded that the estimated probability for a patient to develop a GI complication after cardiac surgery, if the GICS score is greater than 15, is more than 20%. And if the GICS score is less than or equal to 5, is 0.4%. And this has shown a good predictive ability. It has not been the standard of care, but I think part of the reason may be because it is relatively new. This is a view of downtown Philly, what is called the City Hall, a very historic old structure. And this is the Main Street Broad, and our medical school is right around the corner. So let me finish with the last article, which is another recent article in Journal of Cardiac Surgery, and it kind of recapitulates everything that we know so far. The authors did a literature search the last 30 years. They looked at all prospective and retrospective papers, 151,000 patients that had CABG and valve surgeries. They excluded the sick ones, the thoracic and transplant complications. GI complications, 1.2%. Mortality, still high, 34%. Risk factors, pretty much the same. And early diagnosis was the key. So if you can get an early diagnosis, not wait for the patient to have obvious symptoms, was very, very important. So let me conclude by saying that GI complications are rare after cardiac surgery, which is a good thing, but they are associated still with increased morbidity, increased in-hospital stay, use of resources, etc., and hence important. The important ones are post-operative ileus, GI bleed, intestinal ischemia, pancreatitis, cholecystitis, and shocked liver too. We should be aware of the risk factors and try to minimize them. I think personally, though I'm not an anesthesiologist or a CT surgeon, that the GICS scoring system that was proposed recently by the Swedish should be kept in mind, and I think it will find its place. Early diagnosis by having a high degree of clinical suspicion is the key to improving morbidity and mortality. I think that pretty much ends the marathon, but this is, I invite, Philly is, most people know that it is the city of brotherly love. You probably know it is the home of Ben Franklin. You probably may not know that it is the place where the first computer was made. It's true. And you probably know that it is the first capital of the US. So I welcome you all to Philadelphia. It's really beautiful. If ever anybody wants to come there, get my email from Dr. Deepak Puri. Thank you very much for your attention, and I'll take questions.
Thank you, ma'am. Thank you, ma'am, for your very good television, and that your Swedish study was really good, GISCS, so we'll look into it. Secondly, I'm a cardiac anesthetist. We are doing roughly around 1,200 cases per year. And the last 5 years, 6 years are doing on pump. The component has drastically reduced compared to pump cases. So it's a good thing actually.
You're absolutely right. That is, it has, the off pump has. I think we just a little bit more time to say that confidently. Yeah. You're right. That in several years, the cases that are being done off pump are better.
Yeah. Any question from the audience?
Thank you very much, and I'd like to take the opportunity of thanking Fortis for the kind invitation to travel all this way and contribute and listen to very interactive discussion. I'd also like to specifically thank Dr. Arya, who found the time to come and visit us in Melbourne just over 12 months ago, and I think we've already formed a bit of a bond between Chandigarh and Melbourne, so I feel a special note of thanks to Dr. Arya for facilitating my visit. I want to share with you some work that has involved a large number of people, and it's this sponsored by the National Blood Authority of Australia to look at guidelines for patient blood management. 10 years ago, the same body, linked with the National Health and Medical Research Council, we looked at the indications or clinical practice guidelines for the indications for blood. In the decades since, there's been a paradigm shift in the way we think about giving blood to patients. There's emerging evidence that all of you are well aware of in relation to adverse transfusion outcomes. And so we've changed the thinking, if you like, or the thinking has changed away from the product and towards patient blood management. There are three pillars to the principles of patient blood management, and they are absolutely paramount to improving the way we look after patients and genuinely reducing the requirement or the likelihood of us needing to give component therapy. Optimisation of blood volume and red cell mass, a whole range of strategies designed to minimise surgical blood loss, and one of the things that I think is most important in terms of the cultural change is developing a recognition that patients, particularly in the post-operative period, can tolerate anemia. I won't spend too much time talking about the methodology, except to reinforce that this was a very, very collaborative approach. The National Blood Authority 3 years ago convened an expert working group for which I was the anaesthesia representative, and we engaged with professional systematic reviewers to set about looking at the literature in this very evidence-poor field. As I've already mentioned, the focus was going to be on the clinical setting of a transfusion event rather than the product. In order to cover the territory for these guidelines, we decided that it'd be appropriate to look at the clinical setting, and these 6 modules form the component structure of the guidelines. It takes a long time to do. What I'm going to focus on for the rest of the talk is the second module. We completed the module on critical bleeding and massive transfusion in April of this year. As you would probably understand, there's not a whole lot of evidence, and when we looked at the critical bleeding massive transfusion arena, we only made 2 recommendations based on scientific evidence. At least in this peri-operative module, we asked more questions and found more evidence, but still with a lot of inadequacies. So when there was sufficient evidence to make a recommendation, that was done. When there wasn't, and there was still an important clinical matter to be addressed, the clinical reference group developed a practice point. So, what questions did we ask? There was emerging news, if you like, that hospitals, particularly in certain parts of the world, that had started to look at a programmatic approach to patient blood management might be making a difference. There's the perennial question about what about the timing, the cessation and timing of cessation of medications that affect hemostasis, and that challenges us all every day of the week. Thirdly, we wanted to have a look at the range of strategies that have emerged for blood conservation intraoperatively, and obviously this is a huge task. I just want to dwell on a few of these elements. As well as those 3 specific questions that we looked at in relation to the peri-operative module, we applied across all the modules a further 6 generic questions. What's the effect of anemia on outcome? What's the effect of red cell transfusion on outcome? what evidence is there about the effect of non-transfusion interventions to increase haemoglobin? What about the effect of recombinant 7A? And a bit ambitious, but those of us involved in clinical transfusion medicine have always been troubled by what are the right triggers and what is the effect of these components in their own right. Do they do sometimes more harm than good? So they were 9 questions that were subject to systematic review using PICO criteria, which is a very robust way of looking at the literature. The evidence was not just what's the evidence base in terms of adequate randomised controlled trials, etc., and levels of evidence, but also looked at, importantly, other elements of consistency, clinical impact, generalisability, and also, what's quite important perhaps to this audience is applicability, because clearly we were looking at its applicability on the world evidence applied to the Australian and New Zealand population. Again, this reminds us that according to NHMRC guidelines or recommendations that are grade A and B, have a fair bit to hang your hat on, but if you've got a recommendation of grade C, care should be taken in its application. So what I want to do now briefly is to scroll through those research questions and see what we came up with. This question is the only one that I'll put down the evidence matrix, but for every single one of these questions, the question was asked and then the evidence matrix was reviewed, and you can see for this particular question, there was an effect that if you take a programmatic approach to this problem, you can actually reduce transfusion requirements. No effect on morbidity or mortality, and that's not surprising because it's early days. So, recommendation 1, and something that has significant impact in terms of its ability to be implemented, is that it's recommended that healthcare services take on a programmatic approach to patient blood management. Question 2, big topic, very, very challenging, and I won't go through all of the recommendations pertaining to that in the interest of time. But importantly, it's recognised, obviously, that if you don't have to, you don't want to operate on people on dual antiplatelet therapy. You're going to increase the likelihood of transfusion, and so in the elective setting, with or without bypass, cessation of clopidogrel, which is common clinical practice, but again, our literature search demonstrated with level C evidence this is the right thing to do. As far as aspirin's concerned, well, again, almost throughout the period of our review, clinicians have been voting with their feet, and most people feel it's in the patient's interest to continue aspirin up until the time of surgery if they're already on it. And again, that was reinforced by these guidelines, but not with any level of evidence. This is a practice point. And likewise, for those of us that deal with a whole large population of patients who undergo non-cardiac surgery or invasive procedures, you have to take each patient and manage them collaboratively with the cardiologist and the surgeon to make sure that you're doing the right thing by the patient. And this is obviously very challenging. In terms of the peri-operative strategies, I'm going to focus just on the ones that perhaps have a bit more relevance to the cardiac surgery setting. And again, there's level C recommendation that acute normovolemic hemodilution and intraoperative cell salvage are worthwhile to be undertaken in order to help conserve shed blood. However, we strongly feel that to just say, let's go and do it, is inappropriate. If you're going to do it, you need to have a strong local procedural guideline as to how you do it. Antifibrinolytics are pretty much a lay down misere, but again, it's interesting that there's level A evidence for the use of tranexamic acid routinely in cardiac surgery. But all of these measures that I've touched on, the other thing I just quickly rolled over was if you've got the opportunity to apply point-of-care testing with thromboelastography is certainly also very helpful. But what really matters most when we're talking about intraoperative blood conservation is pretty obvious. And I'm delighted that there's so many surgeons. It's really a surgeon's conference, and I can't resist the temptation to talk a little bit about the blood on the floor, because this cartoon reminds me very much of the first liver transplant we did in Melbourne in 1988, and it literally looked like that. 60-litre blood loss, all of the problems that were ever encountered, but the patient did well and survived for 13 years. But I know that your surgeons, all of you as surgeons, are not like this man trying to spear the mammoth. You approach your surgery in a much more refined way, and this term has emerged, white linen surgery, and I think it's a lovely term which needs no explanation. Treat every red cell as though it was precious. And again, we've heard a lot of talks at this conference about the opportunities for progression towards less invasive surgery, and that over time is going to have a big impact on the need for blood. And again, I won't tell this audience about the evolution of emerging technologies. It's important perhaps just to finish off to remind ourselves that blood's often given to treat anemia, and anemia, we wanted to look and see what the effect of anemia was on outcome. We also wanted to see what the effect of red cell transfusion was on outcome. And not surprisingly, anemia isn't good for you, but if you've got preoperative anemia, it increases the chance that you're going to get a blood transfusion. And there's good evidence that that's not good for you either. So there's independent association of increased morbidity and mortality just from having blood. So let's try and avoid it. Therefore, all patients undergoing surgery, whether cardiac or non-cardiac surgery, need to have anemia identified and managed. And there are various strategies for doing this that I'm not going to dwell upon in the interest of time, except to say that when iron deficiency anemia is found, and even patients who are not anemic but may have depleted iron stores will benefit from iron therapy in the preoperative period. We spent a lot of time with some very well-renowned haematologists, experts in iron deficiency, to develop this template which is aimed at a way of capturing those patients and intervening before they come to surgery. FFP and component therapy and recombinant 7A are the last things I want to talk about, but it's important again that we haven't got good evidence here, but we've got a strong impression that there is still a tendency for over-transfusion of patients based on hemoglobin, and we deem that to be inappropriate. Likewise, the tendency to pour in a bag of platelets because it seems like a good idea is not supported. And similarly, and I think things have moved a fair bit, there's much less empiric use of FFP now than there used to be, but it still needs to be curtailed. And most importantly as well, because this drug does work when you really need it, but there's no evidence that giving recombinant 7A in a routine situation is of benefit. More importantly, it may be hazardous. We all know that there are patients in whom everything else has been done and you can get out of jail, but recombinant 7A should be reserved for this situation. So, if you like, these guidelines are about to be rolled out, but I believe strongly there are some take-home messages that are pretty simple. Follow the 3 pillars and try and do everything that we can with our patients to reduce the likelihood of them getting what we might have deemed in the past to be an unnecessary blood transfusion. And I think we have to all think hard about this. It is an invitation, if you like, now to all hospitals to have a look at these guidelines, decide in their own institution what might be achievable and what might be worth working towards in the longer run. I think there's been, for a long time, a and historical approach to blood transfusion that is quite inappropriate. And if you think about the donor, when the donor gives blood, they're giving it as a gift of life. And I can tell you in my career of 35 years, I think we've given a lot of blood because we were treating a number. And through that time now, there's emerging evidence that giving blood to someone who doesn't really need it is a very bad thing to do. Thank you very much.
Do you have a consent form from the patient before transfusing any blood or blood products?
The short answer is that certainly in Australia and New Zealand over the last 2 or 3 years, there's been a huge push to deliver on that. I can't stand here and say that every single patient that gets blood has had informed consent, but certainly now in elective surgery and in the medical setting of elective transfusion, informed consent is obtained, and there's clearly the need for a waiver for people who are coming into emergency department. But there's been a big push over the last 2 to 3 years. And sorry, what's important about that consent is not saying, oh gee, we might have to give you some blood, it's very safe now, you're not going to get HIV, you're not going to get Hep C. It's important to have a conversation and say, well, the risk of viral disease is very low, but there are some other reasons why we'd like not to give you blood unless we really have to, and have some discussion about things like trali.
We did a study in our center in non-cardiac surgery setups. The incidence of inappropriate red cell transfusion was only about 10 to 20%, while the whites, the FFP and the platelets were 20 to 30% inappropriate transfusion. But in cardiac surgery, you just hold your breath. The figures was intraoperatively there was less than 10% inappropriate transfusion of blood as well as FFPs and platelets. But post-operatively, 80% of the FFP platelets were inappropriate transfused. And but good thing was the blood, the RBCs, they were only 10 to 20% inappropriate transfused post-operatively. So there's a need to review all these things, and when we know that we're talking of rat poison, the FFP, I always call it a poison, whether you say rat poison or arsenic poison, I don't know, but it's a poison if not indicated.
I get into trouble sometimes for referring to a bag of blood as poison, but that's another story. Look, I agree entirely. I think we're still in a process of trying to increase our ability to accurately measure transfusion events. And it is very frustrating sometimes when people in the operating theatre are fastidious about doing all those things and trying to reduce blood transfusion, and then find that someone in the ICU or even more likely in the ward post-op are topping up the haemoglobin with a couple of units of blood. And that's the challenge, is to try and overcome that. And the start, and I think that's why having a programmatic approach is so important, is to make the measurements, change the culture, or work on changing the culture, and keep measuring. I'm not very proud of the current transfusion rates in our own hospital, and here am I coming around telling everyone else what to do.
If I may be permitted to make a comment, whether you transfuse 50 ml of platelet-rich plasma or you transfuse 300 ml of blood, it's the same thing. One drop of blood can carry the viral transmission as badly as a whole unit of blood. So I think it is a distinction that one must make. No blood product or no transfusion. We, at the All India Institute, we had achieved a target of 80% of patients undergoing open heart surgery not getting a blood product, which meant even albumin, human serum albumin, plasma, platelet-rich plasma, or RBCs. And we have published that data in the annals of Asian annals, and 80% of more than 400 and odd elective surgeries that we did not receive any blood product. I think it is achievable if one makes an effort and puts in a protocol that is followed by everyone.
Yeah, I just applaud that strategy, and that's exactly what needs to happen. And if people lead from the top and it filters down, that's that's the way to go.
I think we'll wind up the discussion. Thank you, Dr. Larry.
Discuss the importance of peri-diastolic dysfunction, points that I will be covering. First of all, look at what is the evidence that why should be bothered about cortisol. Then we'll have a quick look at the definition and pathology of diastolic dysfunction, how we can assess it, grade, and what happens during the peri-operative period, and what's the treatment that is available to us. Diastolic dysfunction has always been pictured as an archaic, esoteric entity that should be confined to the cath lab or to the research laboratories. The ASE guidelines on subject evaluation has also not made the diagnosis very easy. But recent studies over the last decade, as more and more studies are coming up, which show that patients with diastolic dysfunction, isolated diastolic dysfunction, have an increased peri-operative mortality and morbidity. They also show a high risk of acute decompensation during the peri-operative period. Very interesting couple of studies. Two large cohorts from the North America have shown that up to 50% of the patients with congestive cardiac failure who are admitted to hospitals have well-maintained ejection fraction, which means that they have primary diastolic heart failure. And this study also showed that the patient population who was at risk for that were female population or old age, hypertensives, diabetics, and those who are obese as well. So putting it all together, we will be seeing more and more of these patients in our anesthesia room, and we need to take a bit more careful attention to isolated diastolic dysfunction. How we define it? Physiologically, we can define it as the ventricular relaxation abnormality with a filling abnormality, prolonged or incomplete return to presystolic wave muscle fiber length. But clinically, we can describe it as a syndrome complex characterized by evidence of fluid overload or decompensation in the absence of significant valvular or systolic dysfunction. Now, what's the pathophysiology? The diastolic dysfunction is all about relationship between transmitral, left atrial, and ventricular pressures. We can look at it as active and passive components to its pathophysiology. The active components are factors that affect active myocardial relaxation and those factors that interfere with left atrial contraction. And passive factors, again discussed in intrinsic and extrinsic factors. The most common, most important intrinsic factor will be the LV compliance and factors that affect that, which include myocardial stiffness, chamber geometry, and wall thickness. Extrinsic passive factors include pericardial restraint and the diastolic interventricular dependence. Now, a few words about left ventricular relaxation per se. We all know the dissociation starts with actin-myosin cross-bridge dissociation is the first step in the left ventricular relaxation. Because it is an energy-dependent process, any factor that affects the myocyte energy balance will affect the onset of diastole. So most common in peri-operative period will be myocardial ischemia, and post-operative period may be sepsis. Other two important factors are the contraction, relaxation, coupling. When we say that, the 2 points that we're referring to, one is the LV segmental coordination, and the other factor is atrioventricular synchrony. These two has been very well studied and shown to delay, if abnormal, delay onset of diastole. It has been shown that increased diastole afterload in patients with a challenged diastolic dysfunction can have a delayed onset of diastole, which prolonged time spent in isovolemic relaxation. Preload also tends to delay the onset. Increased preload will also tend to prolong diastole. How we go about analyzing diastole? Okay, we can look at it the gold standard is looking at LV-EDP, which is done in cath lab. But for us clinicians, we need to have two markers. One is echocardiography and parameters derived from, and the other is BNP. BNP was been prone to be of use mainly in systolic failure, but recent studies have shown that a BNP of more than 100 grams per mil has a sensitivity of 86% and negative predictive value of around 96% as a predictor of diastolic failure. Now, just look at the echocardiographic manometer that we can get. Transmitral inflow velocities, we'll be looking at the E value, velocity and time, atrial contraction, the ratios, E wave, deceleration time, which is one of the most important predictors of diastolic abnormalities. Unfortunately, IVRTs are too difficult to be performed in a perioperative setting. We need to do several studies, and they're most better kind to the cath lab. Peripheral venous flow velocities tells us about the three different functions of the LA. The LVA's function as a reservoir, as a conduit for LV filling, and as well as a contractile chamber. The S1 and S2 waves, the D wave and AR waves are the waves that we look for. We also look for the duration of the air wave in relation to the duration of the air wave in the mitral inflow velocities. In severe MR, in the presence of atrial fibrillation and also in the presence of hypertrophied hearts, the interpretations of velocities are very erroneous. So the most recent, the most latest used modality is the tissue Doppler mitral velocities, or otherwise called the E prime velocities. All the studies have shown that E primes are much less load dependent, and the E of transmitral flow velocities to the E prime velocities allows us an estimate of LV filling pressures in a variety of settings. These settings include normal ejection fraction and abnormal ejection fraction, patients with transplanted hearts, patients with air, these are all the situations where these are useful. But the problems with E prime is it has been challenged, its use has been challenged in acute decompensated hearts, and also we have to learn not to take the E prime from the infarcted wall, because E prime can be obtained either from the septal wall or from lateral wall. And in cases of primary severe mitral pathology, use of E prime is very limited. Another modality which may be useful is the slope, the VP, and the LA size is also an important predictor. We have to look at it's an indication of how chronic the elevations of pressures are. There are a few new modalities appearing on the horizon. The most important one is the spectral tracking. Now, once we got all these parameters, we set out to put all these together into an estimation of LV relaxation, and estimate the compliance, and also look at the filling pressures. When we are looking at filling pressures, it is very important to look at patients separate with those with the depressed ejection fraction and those with normal ejection fraction. Once we are done that, we can go ahead and do the grading of the diastolic dysfunction. This is taken straight from the AAC guidelines. They say if the IVRT has limited accuracy and it is useful only in the cath lab things, the most useful technique for measuring relaxation will still be E prime. Either it can be taken from the lateral wall, or at best it is taken from lateral wall and septal wall and an average value. In the patients with depressed ejection fractions, the propagation velocity and the slope of propagation velocity is useful. Now, looking at the compliance, the gold standard has always been invasive calculation of the chamber stiffness constant, but that is still remains a research tool. The best that we can do in the perioperative period is looking at the deceleration time of the mitral E wave. With increasing stiffness, we expect a shortening of the DTs. A wave transit time is another proposed mechanism, but again, that looks at the time taken for the atrial contraction to pass through the LV. Now, once we have got all these parameters, we go about estimating the LV filling. Again, this is taken from the AAC guidelines. Next, we'll be looking at the ejection fractions, and then we grade it. These are all, we need more information. I think we refer to the AAC guidelines. Now, we'll quickly move on to the clinical practice, how to approach this. In the pre-operative period, one group from France has looked at, extensively studied this and come up with a few data, a clinical algorithm to follow, which shows that if there is medical history of diastolic dysfunction, then we need to make, if there is persistent clinical symptoms of heart failure, definitely better to take cardiology opinion and stabilize the patient. If that is lacking, and if the patient falls in the high-risk group, then we need to look for clinical symptoms, then do a proper echo and classify them, and then avoid the precipitating factor. The commonest precipitating factors in the perioperative period is hypovolemia and tachycardia and rhythms other than sinus rhythm. In the intraoperative period, it is very important to again avoid tachycardia and avoid myocardial ischemia. You have to be extremely careful with the loading conditions. A lot of work has gone on to look at the diastolic anesthetic drugs, but no studies is conclusive. And we have to pick our monitoring carefully. In the post-operative period, it is very important to avoid hypertensive crisis because that, as I said earlier, increased afterload can push these patients into failure. Now, how do we treat it? The main treatment is looking at reducing pulmonary congestion. We can use nitrates or diuretics, but we have to be extremely careful in using diuretics in chronic hypertensives because they are already hypovolemic. And then, of course, correction of the precipitating factors. Drug therapy is still very elusive because all we have is milrinone. On the horizon is the work on levosimendan looks promising, but early institution of renin-angiotensin and aldosterone pathway drugs may be the way to go. So in conclusion, even though it is frequently underestimated, it's a very common pathology, and intraoperative hemodynamic variables can affect this diastolic function abnormally, and symptomatic treatments is based on reduction of pulmonary congestion and improving filling. And specific drug therapy is still lacking. Thank you.
Thank you, Dr. Sir. This is one of the very important and difficult topics for us, areas as cardiac anesthesiologists, to catch the patient earliest in the post-operative period who is slipping into the diastolic dysfunction and failure. By the way, what is your regular method there in your hospital? How do you do? Do you do transthoracic echo regular?
In our hospital, in
particularly
ICU,
in children.
Sorry?
Children.
In children, I have to say I don't have much experience in cardiac anesthesia and in children because mine is adult center. But one of the centers close by, all the centers, we use transthoracic echo very regularly in assessing of those pediatric patients.